when it's time to fly, explore, and enjoy. It's also a time to learn. You see, we have long been deeply connected to nature, and once we understand our responsibility to care for nature, we'll understand that it's time to give back. Find your way back to unique experiences that connect us all.
Please visit hawaiicovid19.com/travel for the latest requirements before traveling to Hawaii.
It's a wonderful aloha afternoon here in Honolulu, Hawaii. With me, Peter Tarlow in College Station, Texas. Today is March 16th, one day before St. Patrick's Day. You can see Peter is already all ready for tomorrow. And this is Juergen Steinmetz from eTurbo News and Livestream.travel in Honolulu. Good afternoon, Peter, or good evening, better. How are you?
Good evening. I'm just doing great. Welcome. Good evening from Texas. And yes, you're right. Matter of fact, I wanted to combine honor you and also honor our Irish friends. So I'm wearing a green Aloha shirt. That way I combine the best of Hawaii with the best of Ireland.
Wow, you're really good.
So I try to have something symbolic, but I think, you know, even though most of us are not Irish, I think St. Patrick's Day kind of has a universal appeal, besides the fact that people like to go out and drink. But the fact is that maybe this is a time when we're going to really see the earth being a little bit, you know, we talk about the luck of the Irish, and maybe the earth will be a little bit lucky. And we're going to start tomorrow. We'll be turning the corner on the COVID situation. We need to go back to having festivals. And now I know it's going to be hard because we have to create festivals where people will have social distancing. We don't want to create spreader events, such as the problems that they had in Brazil with Carnival. But we do need to give people reasons to travel. And if we can create ways for people to begin to celebrate holidays again, that's really going to be valuable. We have St. Patrick's Day, Passover is coming up, the Easter holidays are coming up, and these are ways to just get people back, taking almost baby steps into travel again, maybe seeing family, seeing some friends. I think that's really important. So in that sense, we're all Irish tomorrow.
No, absolutely. And today, if you look through the news, it's, you know, the cruise industry has made some headlines with both Viking cruise line and also Princess Cruise Line pausing operation out of Seattle to Alaska and other destinations. So it looks like cruising is not really ready to come back, even though we heard earlier this year that cruises are sold out. So I guess there's going to be a lot of postponements in that industry, and see how it goes. Frankfurt Airport, of course, says their revenue in 2020 is very much impacted by COVID-19, and I think that's understood. And Frankfurt Airport, of course, has airports all over the world, so they're really a trendsetter in the world when it comes to airport operation, and also able to share statistics.
Now, the American airports are saying that even though they don't have a lot of foreign travel, domestic travel in the US has gone up radically. As a matter of fact, I believe last week was the best week since March of 2020 for airline travel. But it's mainly domestic. And I can understand that because you don't know if a country's going to close down, if there are going to be problems getting home, whatever. So if you're in your own country, you have less problems of bureaucracy, but there is domestic travel. Of course, the big issue, and that's something that really has to be thought through, and we've mentioned this before, is terminals. And one of the big problems in international travel is that a lot of airlines insist you be there 3 hours ahead of time. People don't want to spend 3 hours in a terminal. And so maybe we need to come up with some way to streamline that process so that people can get in and out of terminals quickly and, you know, get onto the plane. So that's going to be one of the maybe changes. And on the cruise industry, yeah, I wonder if, you know, a lot of people have signed up. I wonder if they're forced to postpone, if they're going to want to continue, or if they're going to say, you know what, give me my money back.
Right.
Because, you know, maybe you were going on a cruise next week and you had taken the time off from work. And then all of a sudden the cruise is postponed. They say, well, we're going to do this at the end of June, but you can't take another week off from work. So now you have a problem of, you know, coordinating your travel with your professional status or your family status, or you had somebody take care of your children and all of a sudden, you know, you're not going and you paid this person to house sit or babysit. Those are real problems when they change these things.
Yeah, and of course, this is happening to many people, not only in the cruise, also in the aviation industry. I think it happened to you even when you booked your flight to Berlin last year and couldn't go, and you still have this voucher, and it may be expiring a year. Maybe it's already expired.
No, it's still good, but it's that's $900 that United Airlines has that they won't give me back. I mean,
and do you blame them in this situation?
Pardon?
Do you blame them in this situation?
I understand why they don't want to do it, but on the other hand, they have my money now for a year, no interest, and I don't know if I'll ever see that money or not. So, you know, it's a problem, to say the least.
If you lived in some European countries, that's actually a good thing, because I understand if you put money in the bank, there is now a negative interest. So you actually have to pay the bank.
Yes, and as you know, the Biden administration is thinking the same thing. And that's going to be another issue in the United States, because, you know, they're talking about a major rise in taxes, including on all small businesses. And I really wonder, as we're just getting over all the misery of COVID, how well people are going to want to travel if their taxes go up by a considerable amount. And will we have negative interest? And so both of those really may make people a little bit afraid to travel.
Yeah, well, I mean, we're not really ready yet. The travel industry is still very much crippled. And I think once we deal with Corona, with vaccine, we're going to go to the next step. I really don't think
vaccines. Certainly, it's interesting what's going on in Europe with the whole AstraZeneca situation. So many countries now, I believe, France and Germany and Holland and Italy, if I'm not mistaken, have decided to suspend the use. And somebody told me, I haven't had a chance to. Every hour you have to look at the news, that they're now suspending the use of AstraZeneca across Europe. If that's true, and I'm not sure it's true, so I want to make that clear, that's really going to be a step backwards for Europe.
Yeah, no, absolutely.
You know, and you wonder how that's going to, will that start, you know, spread? The US, we've done a pretty good job. We're more and more people are getting vaccinated. I do think the government is right. We will be able to have almost every adult vaccinated in the United States by the end of May. And the American vaccines, the three that are basically used here, seem to be working quite well. And now, of course, the big news and it really will affect tourism also, is Moderna is testing, is in the process of testing one from 11 to 17. And now they're testing one from 6 months of age until 11. And if that happens, that we have a vaccine, that means children will be able to go back to school, that we will, you know, much of the misery that came from Corona, from COVID, will go away. And so let's hope that they're successful in this. The American vaccines have been quite good.
Yes, and that is definitely the case, because it's not only the European and the British, also there are issues with the Chinese version,
yes,
I understand. And so I haven't heard a lot of bad things about the Sputnik from Russia.
No.
Looks like they're doing pretty well.
Yes, it was interesting though, today, the foreign minister of Israel flew to Moscow at Moscow's request to meet with the foreign minister of Russia to talk about joint efforts in the Russian vaccine. So Israel doesn't need to, they're doing a great job of vaccinating, but I think they want the Israelis to approve the Russian vaccine so that it can be used in other parts of maybe Africa and in South America. And yes, I have not heard much negative about the Sputnik vaccine, not like the Chinese. That one's, but it's interesting that the Russians are really seeing this as a export item and possibly something for the use of diplomacy. In other words, to give them a better name.
Right. Well, it's it's a lot of politics involved also in the corona part, you know.
Tremendously. And we see, you know, I think in Germany, Merkel's party lost some important state elections. You would know that better than me. But, and supposedly the way the American and British press are saying it is they lost because they don't like the way she's handling the corona issue. And so it was kind of an it wasn't really anti-her, it was anti-her handling of COVID. Now, I'm not sure she's going to do a better job or not. And that maybe, I'm sure the opposition said that. I'm not sure it's fair what they said.
No, yeah, of course. The opposition is interested in winning the election. Merkel is no longer a candidate in the next election for chancellor. So we're going to see some changes in Germany. I personally have a lot of respect for Merkel. I think she, under the circumstances, she's done a tremendous job. But everyone has a right of their own opinion, and we see where this goes.
Yeah, as I'm not a German, it's not for me to say. I just am reporting the facts, not my opinion. But I do think that what we're going to see is the tourism industry is really at a precipice, and we're going to have to make, as a tourism industry, some real decisions and some real changes. Some of them have been done already. I think the hotel industry has done a really good job of cleaning and of making sure that their rooms are sanitized. But we now have to move from survival to profitability. And that's going to be the key. If we can figure out ways in the tourism industry to give people confidence, make them feel good, and still be able to travel and still earn a profit, that'll be very good. Now, I was at a restaurant tonight with some friends and my wife, and I thought the restaurant did a really good job at keeping people safe, separating us. Everyone was masked, and you felt confident that there was good to go there. So I think the restaurant industry has made some real progress. We have other parts of the tourism industry that are still lacking.
Right, and I have to really say here in Hawaii, that's almost business like usual. I mean, restaurants have been observing the 6 feet distancing, and everyone respects it. So that's maybe why we're in good shape, because people here are, I think, sometimes a lot more disciplined, and it's also, maybe it's a cultural thing here in the Pacific compared to some other regions. Yeah.
One last thing, maybe we should just mention. I know there's going to be a really big article about it in eTurbo News, and I'm going to be looking forward to reading it. But today, something that has nothing to do with COVID. As a matter of fact, it's 10,000 years old, the article. The Israeli Antiquities Society announced that they found not only a basket in the Negev Desert, the Judean desert, which is over 10,000 years old, but they found a child who was mummified naturally that was 6,000 years old, and a number of scraps of some of the biblical books in Greek translation from the Hebrew. There are some Hebrew words in it, but it appears that it was during the Bar Kokhba Revolution, which was about 2,000 years ago. And this will be fascinating because this is, again, real hard archaeological evidence of the whole biblical period. And it wasn't just a story. We're seeing more and more archaeology is proving so much of what the Bible says. So I know they're going to be putting this into just like you have the Shrine of the Book, Heichal HaSefer, in the Israel Museum. There's going to be a whole new part for all these wonderful new discoveries that are really turning the world of archaeology and biblical history on its head and really helping. And of course, this is so important, not only to Jews, but to anybody of the Aramaic traditions, be they Muslim or be they Christian. We're all connected through the biblical text. So right. I know you're going to be writing a really fascinating article about this, but this is kind of like just a an appetizer to get people ready to read the article in eTurbo News.
No, absolutely. Well, we're going to go back to Hawaii. We're going to talk about, actually, we're going to witness a press conference in regards to equal access, I think, to the vaccine, what has been a big discussion point anywhere in the country. And let's see how it's done in Hawaii.
Okay, well, that's great. And I wish you well. By the way, tomorrow is supposed to rain here in Texas. So I'll let you know if we got our rain or not.
All right. Okay.
All right. Have a good evening. Bye-bye.
Thank you. Bye-bye.
Immediate availability to discuss health equity, our brand new health equity report, and vaccine ethnicity data. Some of you have been very patient in waiting for that data. You've been asking for it for several weeks now, and we appreciate your talk to you today to address where we are and what we've learned from our data and where we go. Looks like we have lots and lots of people in, which is fabulous. Just looking for someone from the Star Advertiser. I'm thinking they put someone in here. It would be a shame if they missed it, but I do see television stations, Neighbor Island news organizations, the Civil Beat. So without further, well, let me send one text and then we'll kick things off. Appreciate it. Okay, folks, let's kick things off. I don't want to keep you guys waiting anymore. You're all on time, and thank you very much for doing that. You have waited long enough and very patiently for this information. So again, we're going to be discussing the health equity report and vaccine ethnicity data. We have presenters today that are going to highlight what you're going to see in these reports and talk about the data on race and ethnicity as far as vaccinations go. The ethnicity data will be published daily, Monday through Friday at 12 noon. And so we're going to give you a sneak preview during this media availability. You'll get a chance to look at that data, and it will be public facing in less than an hour. We will also be publishing the entire health equity report at 12 noon today. We got a lot of speakers for you, some from the Department of Health. We've got the head of the Disease Outbreak and Control Division. We have the lead investigator of our Native Hawaiian and Pacific Islander contact tracing team. Also here to assist you today is the gentleman who heads the COVID outreach and public education effort for the Department of Health. We have a public health expert from the University of Hawaii who co-authored the health equity report. We have the executive director of Papaololokahi, which is a group focused on improving health and well-being for Native Hawaiians, the CEO of the Waimanalo Health Center, which is such an important resource to people in that community. So a lot of people here to share perspectives on where we've been and where we're going as far as health equity for COVID and the vaccine data. I hope that you have all now had a chance to at least open that press release and maybe not digest it. But let's go ahead and open things up. We're going to do a Q&A after everyone has an opportunity to share some initial thoughts. We'll do a Q&A afterward and hopefully can wrap this up within the hour. First up, batting leadoff for us here today is none other than our acting state epidemiologist. She heads the outbreak and the disease outbreak and control division here for the Department of Health, and that is Dr. Sarah Kemble. Dr. Kemble, I know you're with us somewhere.
Thank you, Brooks. Good morning, everyone, and thank you for joining us today. Throughout the pandemic, the Department of Health has been committed to health equity for all Hawaii communities. While we still have work to do, I'd like to share new data and initiatives that will help us address the disparities in vaccination administration and the spread of COVID-19. COVID-19 racial and ethnic inequities are linked to long-standing health inequities in cultural communities, including for Native Hawaiians, Pacific Islanders, and Filipinos. Department of Health and our community partners have been working to conduct focused research, outreach, and data collection. The preliminary data that we are releasing on vaccination rates categorized by race follows this trend. Before vaccines were available, Department of Health collected data that has indicated that Native Hawaiians and Pacific Islanders have relatively high hesitancy towards getting vaccinated. 3 months into our vaccination campaign, when we look at the state population as a whole, it lays out the work ahead of us in achieving equity. Out of total Hawaii residents categorized by race, the following have received at least one dose: 25.4% of Asians, 19.2% of Caucasians, 8.8% of Native Hawaiians and Pacific Islanders, 6.4% of African Americans, and 1.9% who identify as other. Due to the Phase 1A and 1B age and employment-based distribution, a smaller number of Native Hawaiians and Pacific Islanders were eligible for vaccination. As we expand vaccination, more Native Hawaiians and Pacific Islanders will become eligible to be vaccinated. I know some of you have requested vaccination data by race and ethnicity and have been awaiting the release of this information. We wanted to be sure we could establish a format that's clear and that can be regularly updated and sustained. And we also wanted to provide a thorough explanation of the data and give you the opportunity to ask questions. We want to emphasize that this data is a starting point and is currently constrained by what we can derive from the National Vaccine Administration System, or VAMS. The national system does not disaggregate Native Hawaiian and Pacific Islander communities at this time. We want to do this and we'll be working to develop a more detailed breakdown to add to this preliminary data. In the next several weeks, you can expect more data to be available in different forms on the website as our data team continues to improve upon and expand the data we share on our data dashboard. This preliminary data is being posted online and will be updated daily on weekdays. Other considerations that are not represented here are income level, education level, access to care, and geographic considerations. All of these things come into play when addressing vaccination disparities. In addition, cultural and ethnic values, vaccine acceptance, and mobility are all issues that may contribute to the disparities. DOH is also releasing a comprehensive report on health equity in diverse populations that details the racial and ethnic disparities in COVID-19 in Hawaii, documents the actions taken to reduce transmission across the state, and provides recommendations based on lessons learned from the COVID-19 response. 2 of the report's co-authors will join us shortly to discuss their findings. The data that we are reporting today serves as a benchmark, and we will report progress as it is available. Thanks to the work of my DOH colleagues and community partners, we have concrete recommendations and goals to inform our work. We're committed to doing more and doing better. Many community groups have already come together to address these disparities and are doing incredible work to bridge the gap, and we will hear about these efforts today. I thank you for your work to ensure that equity remains a key focus of Hawaii's COVID-19 response. Thank you.
And thank you very much, Dr. Sarah Kemble. Next speaker this morning is going to be Chantal Matangi. She is the lead investigator for the Department of Health's Native Hawaiian and Pacific Islander contact tracing team. And if I do say so myself, she has perhaps the best background we're going to see all day. Chantal, take it away.
Thank you so much. Good afternoon, talafalava, aloha to all of you. As he stated, my name is Chantal Matangi. I am the lead investigator for the Native Hawaiian and Pacific Islander contact tracing team. I'm going to be talking about how we came together and who contributed to our equity report. So efforts to mitigate the impact of the COVID-19 pandemic in Hawaii were complemented by grassroots initiatives from within the Native Hawaiian, Pacific Islander, and Filipino communities themselves. As the threat of COVID-19 to local communities emerged, organizations and individuals came together to respond and promote resilience. Recognizing the importance of these important efforts and independent efforts, Hawaii Department of Health invited leaders from within these communities to contribute their perspectives and highlight the innovative and resourceful activities that arose amid this unprecedented pandemic. In May 2020, the Native Hawaiian and Pacific Islander COVID-19 Response, Recovery, and Resilience Team, or the 3R team, was formed to improve the collection and reporting of data, identify and lend support to initiatives across the Hawaiian Islands, working to address COVID-19 among Native Hawaiians and Pacific Islanders, and to establish a unified presence in the decision-making processes and policies that impact our communities. Convened by Papa'ololokahi and comprised of over 50 organizations serving Native Hawaiians and Pacific Islanders, the 3R team, which is further divided into Native Hawaiian Subcommittee and a Pacific Islander Subcommittee, has advocated for change in data disaggregation and how racial and ethnic specific data are collected and reported. Initially, there were no public or private organizations that organized COVID-19 efforts in the Filipino community, despite high numbers of cases. However, in September 2020, the Filipino Underrepresented Scholars Organization, or PUSO, convened and discussed ways to organize and mobilize the Filipino community in response to the pandemic. Members of PUSO, including Dr. May Rose de la Cruz, Dr. Agnes Malete, I'm so sorry, I apologize for that, and Filipino advocates and retired University of Hawaii Manoa professors assembled a Filipino COVID-19 response team consisting of over 25 Filipino advocates, leaders, medical staff, and community members. This work group has met weekly since October 2020 to discuss, support, and promote COVID-19 resources among the Filipino community in Hawaii. In October 2020, the Native Hawaiian and Pacific Islander Priority Investigation and Outreach Team, which also includes Filipino-speaking team members, is a unique solution created by the Hawaii Department of Health, and the team itself is constructed of individuals with novel approaches and that integrate Western science with cultural practices and values to produce innovative approaches that are realistic and respectful to the many diverse Pacific communities in Hawaii. These initiatives leveraged regional history, cultural values, practices, and implemented strategies that applied to very specific communities. So rather than placing the burden of the pandemic response on these communities most effective, these initiatives or these innovative approaches empowered them by supporting their grassroots efforts to create their own narratives and shape their community-specific solutions while following public health guidelines. While implementing the COVID-19 awareness campaign and educational efforts, it was essential for my team to ensure that the messaging was light and friendly. So we looked to avoid common guilt or fear-based tactics when motivating a community to adhere to health guidelines or to change behaviors. We also understood that when we were asking them to change these behaviors, that we were asking them only to do it for a small amount of time and in conjunction with them. So we didn't look to tell them what to do, but rather we looked to find ways to incorporate their cultural practices, but to make them COVID appropriate in order to protect these communities. These efforts are seen as a great step forward. They are unique and program specific to Hawaii. And we are actually receiving national recognition from the CDC for this. And of course, our hope is that in moving forward, Hawaii will continue to support these collaborative relationships and incorporate this into other departments statewide. I appreciate your time today, and I'll turn the rest of my time over to May Rose, or back to Brooks rather.
Thank you very much. Do appreciate it. I believe next on the hit parade is going to be May Rose de la Cruz, is an expert with the University of Hawaii in Native Hawaiian and Indigenous Peoples Health, and she is also a co-author of the equity report that you're all going to see today. So take it away. Thank you.
Aloha and thank you. Salamat. Thanks, Kelly. for going over the report. I'll be going over the responses and the recommendations right now. An important part of this report was to highlight the responses. There were two types of responses. First is the public health response, and that was conducted by the Department of Health using the contact tracing program, and also utilizing different materials translated for the ethnic groups represented in Hawaii. But a valuable and a much needed response was the community response, which I was completely a part of with the Filipino community, and I'm very proud of working with our Filipino community through the PhilComm's Cares project. The PhilComm's Cares project was with the Filipino Community Center, along with the legal clinic, and currently now with the Hawaii Public Health Institute and the PhilComm Cares project, where we looked at different venues that was appropriate for the Filipinos here in Hawaii. And one of them was the Radiothon, which we conducted in November. And we talked about COVID-19 in our native languages of Ilocano and Tagalog. Along with the Radiothon, we also made culturally relevant and tailored materials in Ilocano and Tagalog in partnership with Department of Health. And we also did COVID testing at Catholic churches. 90% of Catholics here in Hawaii are Filipino. I also wanted to highlight another great community and outstanding community response was the We Are Oceania project or program with the Micronesian populations. They helped come together and made a helpline in their native languages and had many, many outreach activities regarding COVID testing and also supporting their communities with food drives and making appropriate materials. This is really important to have community response because it is the community who will provide insight on what the community needs. We also had 6 recommendations in the equity report. I would like to only highlight 2. The first recommendation was to advocate for standardized, complete, and accurate data. This is important to be consistent with ethnic categories and to continue to disaggregate data. Through this aggregation of data, we can see through the cases and mortality rates which ethnic groups need the help. And we're hoping to continue disaggregation of data with the vaccination clinics, who's getting vaccinated, who isn't, and also which populations are getting services. The second recommendation is to collaborate with community orgs and develop target informed messaging, which we saw in the community response. Only the communities understand which venue, which mechanism is best to deliver the messages. And we did it through print, TV, radio, or even TikTok. And we also translated materials. The remaining 4 recommendations are basically circulating around community involvement regarding how to speak on the data, share the data, how to organize and to help minority populations be part of the whole dissemination of data, integrating into policies. But thank you so much for letting me speak on this. It was a great collaborative effort, and hopefully we'll have more community involvement in future reports and future data dissemination. Thank you.
Thank you, Dr. Dela Cruz. Very much appreciate it. Next up for us is Christopher Johnson. Chris Johnson, known affectionately to us as CJ. He heads the COVID outreach and public education program here for the Department of Health, and there is a familiar face to us all. He's been doing wonderful work for since long before I joined the Department of Health, getting out into the community, networking, establishing partnerships, and building trust. And CJ, the floor is yours.
Thank you so much, Brooks. So I'm CJ Johnson. When we're not in a pandemic, my role at DOH focuses on chronic disease prevention and health promotion, where we work specifically on diabetes, heart disease, other conditions that are impacted by what we call social determinants of health. And what that means is that we focus strongly on how factors like occupation, socioeconomic status, and our living environments either support or create barriers to health. And what we know from this work is that owing to generations of unequal access to supportive environments, healthcare, and health information, racial disparities in many chronic diseases are persistent and compounding. So that's relevant today, that's critical even today in today's conversation, because as we've seen at every scale from national to local, these same risk factors, both the social determinants and the chronic diseases themselves, are also the driving forces behind our racial disparities in COVID cases and outcomes. They also play an important role in understanding the disparities in vaccine rates, and they help us strategize how to address them. So there's at least two different issues, which Dr. Kemble mentioned earlier, that contribute to vaccine rate disparities, and they break down roughly to access and interest. From even before vaccines arrived in December, we anticipated them and have been cultivating and formalizing a large network of community partners, many of whom you've already heard about, to address these challenges. So varying levels of enthusiasm for vaccination among different racial groups is expected. We've had surveying that supports that. These are informed by personal cultural history with healthcare systems, but through partnerships with a number of organizations, we've been able to develop information campaigns that are more responsive to community concerns and values, and that empower communities to make informed decisions about vaccination. So over the past year, we have, as Telly mentioned, stood up an NHPI contact tracing team with language skills, local cultural knowledge that provides extensive outreach, not just in contact tracing, but in prevention, management, and in vaccination. We've worked with community partners to develop a really robust library of COVID-19 and vaccine guidance in over 16 languages, which is available at hawaiicovid19.com. We've developed a series of testimonial videos featuring cultural and health leaders in the NHPI and Filipino communities. And we've dedicated funding, specifically dedicated funding to a number of organizations on the ground reaching out to these populations. And I want to say these critical partners who are already in the field, already making a difference, that we've been able to formalize relationships with, like Papa Ololokaihi, who you'll hear from in a minute, Marshallese Community Organization of Hawaii, Philcom Center, Project Vision, We Are Oceania, the Hawaii Public Health Institute. So by partnering with these groups, we have increased our educational reach. We've identified key influencers like religious and business leaders, and we've prioritized the most relevant messages and channels to maximize that impact. So the other part of the process, which I mentioned, is access, where language, technology, and mobility are known concerns. And some highlights of the existing access work include funding a series of UH courses intended to upskill bilingual community health workers, or CHWs, to share COVID-19 vaccine information, piloting an outbound in-language phone bank system to identify and support kupuna who are not online and may have language or mobility barriers to getting vaccinated, supporting targeted vaccination events. So far we've supported Chuukese and Filipino vaccination events on Oahu, and a number of other language-specific drives are in the works across the state. And today actually is the first in a series of on-site max vaccinations at Hawaii public housing facilities that are senior facilities that we've helped coordinate print and on-site language support for those events. So again, the equity data on the dashboard and in the report is not a surprise to those of us who've been doing this work, but they are compelling evidence that the existing effort is justified, that much more needs to be done, and that even as we struggle with these inequities, strengthening the partnerships that shaped this report and so much of this outreach work is an opportunity to shape a more inclusive and equitable future through empowered partnerships and targeting resources where they're most needed. So with that, I would like to hand the spotlight over to Dr. Sherry Daniels, Executive Director of Papa Ololokaihi, to talk more about the critical role that they have played in COVID-19 response, recovery, and resilience. Sherry?
Velina mai kako, mahalo CJ for bringing me into the loop. I want to thank Telly for kind of giving an overview of the 3R team that Papa Ololokaihi, along with others, have worked to uplift. And really what we looked at is the importance of this data report is really going to allow communities as well as policymakers the ability to support the ongoing efforts that we've seen over the last year. One of the biggest challenges is how do we shift policy and how we move forward. And as you saw in the first slide that Dr. Kimball shared, for Native Hawaiians and Pacific Islanders, 8.8% have been vaccinated. And that's one of the reasons the 3R team back in the fall really pushed the National Academy of Medicine to prioritize our population as one of those vaccination priority groups. And that did come out in their report. And so things like that low number was of concern for us. So in working with the Department of Health to make sure that in-language messaging and support was done, really helped to upscale our work with the community. And we really saw ourselves as a bridger between the efforts that the Department of Health is doing and those in the community. One of the things I did want to highlight is Hawaii is the only state that further disaggregates the data for positive cases. So no other state in the US takes our NHPI numbers and further disaggregates it to see how NHs look comparatively to Pacific Islanders in terms of positive rates. And we're hoping that the same scaling can be done for the vaccination data as well, so that that information really helps communities better message. It helps us to understand where we need to put our resources. The resources that we have been able to bring into our communities is to help them push forward vaccination rollouts in partnerships with FQHCs or the Department of Health or other providers such as Kaiser Permanente to really get vaccinations into communities. I believe that we talked briefly about hesitancy, and I really want to kind of talk about that a little bit, that for our Native Hawaiian Pacific Islander communities, the perception of hesitancy is one that we want to shift and really talk about the concept of kilo, and that culturally, kilo is a time, is an activity of observation, that we're not jumping quickly to an action, that we're taking our time to really gather information, be thoughtful in our response, and really to look at how being vaccinated and making those choices has impact not only on ourselves, but on our families and within our communities. So instead of looking at it as hesitancy, that we're looking at it from a space of being in kilo, that we want to look and we want to observe before we move forward. We're hopeful that the changes that we're seeing and that all this information and the gathering of entities coming together, both at the state level, at community-based organizations, and even with those bridging organizations, that we can see policy shifts moving forward, that we can change the way our system, the mechanisms behave, so that we can truly support the efforts that are being done in community today. So with that, I'd like to pass it over to Dr. Mary Oneha from Waimanalo Health Center.
Aloha, mahalo, Sherry. Thank you for that. To ensure that the nation's underserved communities and those disproportionately affected by COVID-19 are equitably vaccinated against COVID-19, the Health Resources and Services Administration, or HRSA, and the Centers for Disease Control and Prevention, or CDC, launched a program to directly allocate COVID-19 vaccines to HRSA-supported health centers. So in their first phase, 250 health centers were invited to participate. In the second phase, an additional 700 health centers have been invited to participate. 12 out of 15 health centers in Hawaii were invited to participate recently. The health centers that have been invited to this program serve a large volume of one of the following: individuals experiencing homelessness, public housing residents, patients with limited English proficiency, those who have low income and minority patients, and those programs that utilize mobile vans to deliver services. The allocation provided for this program is separate from the jurisdiction's weekly allocations, or those allocations that we currently receive from the Department of Health. There are several steps community health centers need to complete before ordering vaccines through this program. Health centers follow state priority guidelines in administering the vaccine to their patients and are allowed the flexibility to administer beyond those guidelines to our disproportionately affected communities and those populations with health and socioeconomic vulnerabilities. So we appreciate the support from the Department of Health and our Primary Care Association, and are excited to accept the invitation and support from the federal government. We highly encourage vaccinations for all those eligible, and will continue to reach out to our patients to schedule their COVID vaccine appointment and continue to think of ways to expand, particularly since all 3 vaccines will be available to us, to our underserved communities and those disproportionately affected. Mahalo.
All righty, thank you very much. I appreciate it. Reporters, I know that that is a whole lot of information to digest, and you have yet to see this full report and have time to read that and digest it. You just got a very quick look at some of the numbers, so we can get those up again on the screen for you during Q&A if you would like. But it is now time question and answers. I know there are a lot of questions out there. And so let's do it this way if we can. It has been suggested that we ask people to raise their hands, but everyone has been so good in the past. You guys have all played so well in the sandbox with one another, giving each other time to ask questions and even a follow-up question when needed. So hopefully we can just have a free-flowing conversation, but if it gets a little out of hand, we'll go back to the raising of the hand. I do see that hands are already up. Let's go to Daryl Huff and then Kristen Concilio. We can get a question for you, the Star Advertiser. But Daryl Huff, what can we do?
So where's the data on Filipinos? How do we find it? It's not on your slide.
Hi, I can take that. If Brooks, are you going to put up the, or Katie, you're going to put up the numbers again? So the vaccine data is currently limited by the categories available in the Vaccine Administration Management System, which is the federal data system for collecting vaccine administration data. And these are the categories that are collected federally. So as some of our speakers referenced, the work that went into the health equity report was based on disaggregated data that we do collect for cases here through our data systems in Hawaii. We are working with the federal system to try to get disaggregated categories for Asian and NHPI here so that we can do the same with vaccine data.
So Doctor, what can you tell us about what's happening in the Filipino community then? I mean, you guys showed quite a lot of interest in it. You have a lot of people working that community. I understand that there is a lot of hesitancy and that it's kind of dissembled where the various people are getting their shots. How is the Filipino community doing in your estimation?
Right, that's where that disaggregated data is key and why we are working hard to get it disaggregated. We don't have great visibility through the federal data on those groups within the Asian category or the Native Hawaiian Pacific Islander aggregate category.
Is it okay if I address that question, Daryl? Thank you, Daryl, for that question. So, being out in the community, and we've noticed this with our community, we've been meeting almost every week with the Filipino organizations, and we've noticed the issue isn't vaccine hesitancy with our group, it's vaccine access. So that's why we've been going out, doing more outreach activities and working with the Filipino Catholic clubs to make sure that our elderly are going to get vaccinated at the Catholic churches. There's a great mistrust sometimes with the medical community. So if the church promotes it, and our first vaccinated Filipino location was the bishop. He's not Filipino, but he was vaccinated and he wanted to show that he endorses vaccination. So if there's more access to the vaccine, more Filipinos are willing to get it, especially since many of us are frontline and essential workers. But we are hopeful that much of that Asian data gets split, and we would like to see if our Filipinos are getting vaccinated because we are providing a lot of places where they can. Thank you.
I think you just answered my question about where it is. So they are within the Asian category then?
That's where they usually put us, yes.
And if we can, let's go to Kristen Concilio. Kristen.
So, sorry, I think I heard that the issue is not so much hesitancy, but maybe waiting and watching for Native Hawaiians. And then did you say access for Filipino community? Is that what you just said? Sorry.
Yes, thank you.
So
it's,
oh, go ahead.
So regarding Filipinos, it's hard. Like I think a lot of us, there's language barriers with our elderly populations. The registration process is very cumbersome and the health literacy level is really high there. So what we've been doing with the Catholic churches is we do registration a week before the vaccination clinic at the church, and then we do the vaccination a week later. So we're up there in person helping them getting registered, because a lot of times you don't have internet access for them, or they don't have, they don't understand the whole process. So just being there out in the community and helping them understand the registration process and know when to get it and then they will stand in line. They will wait for their turn and they would like to get vaccinated.
So what kind of policies need to be changed in order to, help with this issue?
It's been great that the Department of Health and the state's been helpful with a lot of giving us access to vaccines. But I think a lot of the push really needs to be a pattern and a habit of doing that in any case regarding public health. To push it out in the communities, the pod started off at Kaka'ako. Our elderly don't have access to that. They're not seen at Kaka'ako. Sometimes it's not within the bus line. There's no transportation for them. So I think it's best to push it out in the communities, the Catholic churches. That's where we're at for Filipinos. So I think that's the case for many of our vulnerable and minority populations. Bring it to the rural communities and help us get it out to our people.
For Native Hawaiians, I just want to chime in, similar to what Mayor Rose had said, that for our community, it's not that we're not wanting it, is we want to understand, we want our questions answered, we want to see what happens. Messages can be very confusing. The platform is confusing for many in our community, and we're finding that they often need some additional help, multiple in many of our communities, right? It's not just giving them the link, it's how do we help them register? How do we help get them to those sites in their community? So it's really looking at community partners so that the access is closer to their homes. It's also helping them fill out the forms there, but also checking in with them so they know that they have a second dose that they have to come back for. And what does that mean in their community? So it's helping communities really band together in a way that they already do, but to support those efforts with funding, to help support pay for community health workers that are helping register, helping check in, making sure when we have events that there's opportunities that messaging can be put out to them as well so that they can share more word of mouth with their community members as well. So it's really taking a multi-pronged approach, but also making sure we have information that are not only linguistically correct, but also visually correct. The Papololokahi, along with our 3R team, will be releasing a vaccination toolkit, and that is in partnership with some Native Hawaiian and Pacific Islander organizations across the nation, that we wanted to make sure when we look at creating a toolkit for our community, that it was not only in language, but it was also visually appealing so that we can help them. But it's also helping our communities have access for funding, for support, so that they can do their best as well.
And I am so sorry, I'm going to add one more thing to this. My apologies. I think that it's also important, especially as we're doing educational outreach, something that's been coming back over and over again is making sure that we have Department of Health workers who speak their language, understand their culture, and who are able to communicate it in a way that they understand. Recently, I was a part of a discussion where one of the community members had stated, I received a call from a contact tracer and they used an interpreter. And while I appreciate the fact that the effort was being made, the next call I received was from an actual contact tracer who had been trained and who spoke the language. And so as we had this discussion, because the person on the other side of the line understood the process, they were able to further tease out what needed to be done, what needed to be offered, and had a richer, fuller conversation that was not only in language, but also made sure that there was comprehension, that they understood what was going on, which is, again, what we're also hearing from the community concerning vaccination, which is why part of our outreach also includes vaccination. And we partner up with CJ to make sure that we're presenting it. It's factual. It's whatever the Department of Health is putting out. It's up to date, but also it's in language and culturally appropriate. So I think that's important to note, and amazing job by the Department of Health.
Thank you, Telly. We appreciate that. I see Nicole Tan has a question, but she has indicated to me she has a question that is a little off topic. And so if I may, let's go to Juergen Steinmetz next, who has his hand up.
Yes, my question maybe is also a little bit not off topic, But I'm wondering, the visitors industry has some of our guests that are staying long-term and actually were encouraged to come here and work away from home so they can fulfill the quarantine requirements. They're both domestic visitors and also international visitors in Hawaii. Do they have access to our vaccine program?
So the vaccine program in Hawaii is focused on people residing here in the state, and people are asked to provide proof of residency when they go to get vaccinated.
Thank you.
All right, and Nicole has indicated to me that she does have an on-topic question. So Nicole Tam at KITV will take that, and then we'll try to circle around if we have time at the end to your off-topic question. But Nicole, something related to today's topic.
Yes, thanks, Brooks and everyone. So many speakers spoke about like community group involvements to get people vaccinated. What's an initiative that works besides educational outreach? Is it just ramping up efforts to get shots out to communities, like to churches, like you mentioned, or more educational discussions are needed to specific communities in their language, perhaps? But pretty much, what are initiatives that works to really get people to want to get the vaccine?
I'll take that, I guess. I think there's, so as I mentioned in my presentation, I think there's kind of two separate concerns, right? So one of them is the education or the interest. I agree that I don't like the term hesitancy. I think it's very reasonable to have questions and want your questions answered in a way that's resonant with you. So interest and access. So we are not, we're dealing with both of those at the same time, and I guess in different people and different populations and different communities and different ages certainly are at different stages in that process. And so at the same time that we are reaching out and trying to make sure that we have answers to the one-on-one questions I mentioned on Hawaii COVID-19.com, we do have our FAQs that are things like, how does mRNA work? Or what are the side effects of the vaccine? Or what do I need to bring with me to my appointment? Things like that are just things that help people feel more comfortable. We have some, like I said, testimonials from influential leaders that again are intended to help people become more comfortable and normalize being vaccinated. So that's part of it. And then the other part is there are, we've talked about a lot of them. There are language, there are technology, there are geographic, there's mobility barriers. And these are all very complicated, and they intersect quite a bit in terms of the populations that are most vulnerable. So there's a lot of communication work, there's a lot of outreach work that is being done. We have funded a number of these organizations that were already doing community work, right? They were already out and working before there was vaccines. They were getting masks to people. They were translating their own material to their communities to make sure people understood hygiene and precaution. So what we've been able to do is fortify those relationships, provide guidance, and listen, right? It's not a broadcast, it's not a one-way relationship. We're listening to the community partners and hearing what concerns are, and then trying to figure out how we can transfer from these pods. Like the pods were designed specifically to get lots and lots of people in and out. And when we had a limited supply and when we were early in the process, it was really important to move a lot of numbers, right? That herd immunity is the finish line. But we also saw from this vax data that the consequence of that is that we don't have an as equitable distribution as we'd like. So we're working with those same partners we've been developing relationships with for years and really focusing for the last year to identify the specific individuals, the specific neighbors, the auntie that's not online, the auntie that can't leave the house, the neighbor who doesn't speak English, and helping people. And we are trying to get them the resources and fund work that is doing that really labor intensive, really time intensive outreach to make sure that we're not leaving those folks behind. So I think it's two separate but related challenges. And they're, as I think I've been given my 101 thing on webinars and stuff for 2 or 3 months, and you feel like, gosh, doesn't everybody know it by now? But the reality is a lot of folks still haven't heard it, or a lot of folks still haven't made up their mind. So we're continuing to do that part, the education, and also really trying to think through the barriers and how we can address them.
And I just wanted to add that the other side of this is making sure that vaccines are going to providers who these communities are most familiar with and comfortable with to begin with. That's been a large part of the emphasis on federally qualified health centers. We're very grateful for the federal program that's allowing us to even further expand vaccination through federally qualified health centers. But from the beginning, one of our top priorities has been to make sure that all the doses that can be absorbed through the federally qualified health centers and other providers that are serving those communities are met. So that remains the goal for ongoing vaccination, to make sure that resource is fully utilized. I don't know if there's any additional comments that Dr. Oneja would like to make on the FQHC perspective.
No, I agree with what you just stated, Dr. Campbell, and what CJ shared. I think it's a combination of factors. I don't think there's an ideal set of circumstances in each community. I think it's different in each community, but definitely education and access are key components to people getting vaccinated. And access not only includes community access, cultural access, but having transportation available, calling them on the phone as opposed to having them go through the internet to schedule their own appointment, providing assistance with the pre-vaccination checklist, scheduling their second appointment at the time of their first appointment. It's just a number of supports that are needed to be in place to assist the populations that we are serving.
All right, thank you all for that. Anita Huffler has asked questions for quite some time about this topic, and I'd like to give her an opportunity to ask a few questions that she's got on deck. Anita.
Thank you so much. And thank you all, everybody at DOH. I know you guys have been fielding my questions for several weeks now, so I really appreciate, this press conference today. And so the first question I had was a follow-up to what Daryl was asking about more specific data. I understand that the VAMS system has broad race categorizations. My question is, how specifically are you going to be able to get that more specific data? Because people are getting vaccinated right now and they're sending me like screenshots of their vaccination questions that are only those broad race data. How are you going to know like how many Filipinos have been vaccinated? Do you have to kind of like call everybody back the way that it worked for the COVID-19 cases, or is there additional way that providers are obtaining that information currently? And also, what is the timeline for getting that more specific breakdown? I understand it's complicated, but what is like what should we expect in terms of when we can see those breakdowns, specifically for disaggregated data for Native Hawaiians, other Pacific Islanders, and Filipinos?
Thanks for that question. The answer is some of both or some of each. We have been asking sites where feasible to use a paper-based form in the meantime that also collects more specific race categories. So for those sites that have been able to do that, we are collecting back those forms, and that is that process of trying to go back and backfill some of that information. Other sites, including many of our health system sites, may be able to collect the specific race information through their medical record systems. So as we're still in the process of getting our immunization information system, the Hawaii Immunization Registry, back up and running fully. So as those providers onboard, we can extract data on race for those vaccinations that already occurred to some degree through that method. Finally, we have asked the Centers for Disease Control and Prevention from the beginning, when we began using VAMS, to add specific race categories and disaggregate the Native Hawaiian and Pacific Islander category, as well as the Asian race categories. We did get word recently that they have heard our request and are working on disaggregating those fields in VAMS as well. So we're happy to hear that. If I have a timeline from them, I will share it with you.
So at this point, there is no specific timeline for this, or it's unclear?
I think realistically, we're more likely to get this kind of information going forward prospectively. We do hope to at least complete enough of a retrospective review of the various other methods we can capture what's already happened to get a snapshot. But I think most likely we'll have more robust data moving forward. That would be, I'm hopeful that we'll have some of these solutions come through within the next few weeks. But again, we are somewhat dependent on the federal systems to make those changes, and we're working on that.
I was also wondering in terms of the, the 8.8% vaccination rate for the NHPI community. I was wondering like how you feel about that. Like when I look at that and I see 8.8% is vaccination rate and 41% of cases are affecting that community, like what would you like the public to take away from the differences in those numbers? Like what is your reaction to that?
The first reaction, as CJ was saying, is those numbers are not unexpected for those of us who have been working on these issues. And there's a couple of reasons. It doesn't mean that they're acceptable, but it is not unexpected. And one reason is looking at how we have allocated vaccine based on the recommendations from the federal government and the Advisory Committee on Immunization Practices. The very first prioritization group was healthcare workers. Well, as we look at who are healthcare workers in our state, we see underrepresentation of Native Hawaiian and Pacific Islander groups in that category. So obviously, if we're prioritizing vaccinations for a group that doesn't represent NHPI very well, then we're going to see lower vaccination rates for that group. We then moved on to those 75 and older. Well, if we look at our demographics in the state, unfortunately, Native Hawaiian and Pacific Islanders don't have as long a life expectancy in this state. So we have fewer people in that category. One of the things you'll be able to see on the new dashboard is both the percentage of the total population vaccinated to date, as well as the percentage within target age groups, so the 70 plus age group. And so when you look at it by age, the disproportionate representation is not as apparent. So looking at those who are in the older age category, the proportion of NHPI vaccinated is much more on par with the other age groups. It's when we look below that age range that we see more of the disparity. And that's where we really need to focus this effort, as everyone's been saying, on the interest and access, reaching out to communities, going to where they are to make sure that they are able to get vaccinated, understand the benefits, and can get their shots.
When I talk to advocates for the NHPI community, they say that one way to improve access is to make their community a clear priority, or to prioritize certain zip codes that have been hit hard, like in Kalihi, or to prioritize zip codes with overcrowding. I'm just wondering, like looking at the disparity as you see it now, do you have any desire to change the prioritization, or would that have been helpful in retrospect? Or is this, do you still think that the prioritization categories were the way to go?
I think there were good reasons to start with healthcare workers in the 1A category, and that was agreed on nationally. I think now, as we move into 1C, we have a real opportunity to tackle health equity head on. This is the group in which we really do need to make sure that we are reaching those areas both geographically and demographically that need the most outreach. And so I think that the numbers that we see here as baseline are what we would expect from how the prioritization was handled initially. And I don't think it's wrong. I mean, I think we have to make sure our health systems are able to be resilient and to not be fearful that if we had additional COVID surge, that we wouldn't have the healthcare system capacity to deal with it. That affects everyone, no matter your race, your age, your culture. But as now that we've done that piece, we've vaccinated most of our healthcare workers, it is really looking into the community now. Where are we seeing the highest risk? Are we reaching those populations? And that's really the work ahead of us here in phase 1C.
Yeah, I just wanted to add that the federal program does prioritize the public housing residents for the program, and both health centers in Kalihi, Koko Kalihi Valley and Kalipalama health centers have been invited to participate in the federal program.
All right, and time is getting short. I still see some hands up. If you don't have a question, you could take your hand down. That would help me. We of course want to answer as many of these things as we can, but as you know, we have lots of work to do here. We have not had a chance to go to Hawaii Public Radio. So Jason, do you have a question for members of our panel? And if so, who? And what's the question?
Let's see. All right, can you hear me? Okay. I don't have a question specifically for anyone, but for the department. So I know you're collecting the data, trying to disaggregate it. But I've also heard that you're not surprised by some of it, and maybe even with the vaccine rollout, not surprised. It's kind of overlaying chronic conditions, the COVID testing, and who's getting it. So how do we know that? Why collect it, and how do you know you're making a difference with your with the outreach and rollout, and how do you communicate that to us that, you know, collecting this data and acting on it, that it's making a difference, and you know, the people who need to get vaccinated get vaccinated?
Right. I think that by continuing to show the data and how the needle moves day to day, week to week, is how we can now hold ourselves accountable for our vaccination efforts and whether we're making dents where we need to. So that data is where we flow from. It is the beginning of that process to see are the activities that we have implemented, the actions we are taking, are they working? Like I said, I think that this is the appropriate time to really be tracking that, because up till now, there have been some limitations to how vaccine is prioritized that would not have impacted these groups as greatly. But now, as we move forward, we should be able to see that needle move. And if we don't, or we see it lagging in one area or the other, this is how we can track that and change course as needed. This whole pandemic really has been about being ready to be adaptable and meet the challenges where we find them, and being able to see the challenges is the first step of that.
I hope you don't mind if I add to that, because I do a lot of educational outreach, and I'm dealing with Native Hawaiian, Pacific Islanders, and Filipino community members. The reports that I'm getting back from the community, and also those community leaders, is that as we have added language and culture, they have seen that their numbers are going down. The community is isolating or quarantining properly, that they understand the steps that are needed to be taken in order to flatten the curve. They're also receiving the resources that they need, which is instrumental. If you're suffering and you have to stay home and you don't have food, or you don't have access to an ISO quarantine unit, then of course you're going to stay home. You're going to pass it on to everybody else. But if you have someone who speaks your language, who understands what's going on in your home, be it multicultural or whatever, multi-generational, they're able to come in and say, how many people are in your home? How can we best assist you in making sure that we can separate you? And how can we support you? And how can we get you in touch with these additional agencies to support you through this effort? So I know for me, my team came into existence in October 2020. Our numbers for the NHPI community were high. They have come down, not as much as we would like it to, but they're continuing to come down. And as we continue to have this education and this outreach and to be there for them, our hope is that that will continue to happen, and that we'll be able to put this also with the vaccine. And I see Josh's camera is on, so hopefully he can actually give you those numbers. So I'll turn it over to him.
Yeah, I know we're short on time, but I just wanted to chime in to the role that we see data playing on these issues. And so when it comes to the vaccination data, we are looking at trends over time. So today's posting will just be a first baseline, as Dr. Kemble mentioned, and then we will be providing ways to analyze the data so that we can track our progress towards the goals that have been mentioned, and to be able to evaluate the effectiveness of all the outreach activities that are happening. Thank you.
And I know we've already gone into overtime. Dr. Kemble and any panelists that are still with us, I know a few people have already had to drop off, but do you have another minute for a couple minutes for the last couple questions?
I have a couple minutes, yeah.
Okay, just a couple minutes. Daryl, can we go to you for one question, and then we'll go to Kristen?
Sure. You have current priorities. One thing, if you wouldn't mind, I'll put this in two parts. First, where the communities in these that are being served by the healthcare centers, were they being prioritized in the same way as other people? That is stage 1, stage 1B, 1C, and so on. And two, Now that you've decided that you're going to prioritize hotel workers, bars, restaurant workers, and so on, is that in a way taking away from your ability to serve these communities? Or how are you balancing that at this stage? Because it really does seem that people that have the most infections are getting the least vaccines.
I can speak to both of those. So for the healthcare centers, we, as referenced earlier by Dr. Oneha, we have always allowed flexibility there for the health centers to vaccinate their populations more broadly. So we have not held them to the strict age and occupation-based categorizations. And that is with the recognition of the need for health equity there to give a head start to those communities in terms of vaccination. As far as the current prioritization for hotels, restaurant workers, and bars, in fact, when we have looked at our recent case and cluster data, our clusters have been dominated recently by outbreaks occurring in those specific settings, hotel workers, restaurant workers, bar workers. And we have also observed associations that many of the workers impacted there are from Pacific Islander communities in particular. So that is part of that prioritization there. So I actually am hopeful that by placing that as our next immediate prioritization, we will be able to move forward more rapidly on vaccinating those populations most impacted and most needing the vaccine.
Thank you, Daryl. Thank you, Dr. Campbell. Let's go to Kristen Concilio for one last question, and then Nicole Tam, and I think we'll have to wrap it up. Kristen.
Okay, so I want to know how many vaccines have gone to the health centers and how many have been returned in terms of unused because of this issue.
Yeah, we have had very few unused or returned vaccines in general. So I don't have exact numbers, but I can say there has not been a trend of unused or returned vaccine from the health centers.
Can you just tell us how many have gone to the health centers in these communities?
I would have to get that to you later. I don't have the distribution numbers current as of now.
Thanks, Kristen. Maybe you can follow up with me and I'll see if I can't help you with that. And Nicole Tam, you have a question. I believe you're going to get the final word of the day.
Thank you. This question is for Dr. Campbell. So Moderna is doing a vaccine trial for kids aged 6 months to 12 years old. What are some risks for kids to get the vaccine? And is it too early? Do you think it's necessary for kids that young to get a shot, considering the infection rate for that age group is quite low?
There are trials ongoing for children for some of the COVID-19 vaccines. The trials are being run to assess just that, the safety and efficacy of vaccine for pediatric populations. You're correct that the initial projections would show that herd immunity could be accomplished without vaccinating children. And in general, children suffer less severe health effects. That being said, we do sometimes see these post-infectious complications like the MIS-C syndrome in children. So that is an immune reaction that occurs several weeks after being infected with COVID-19 and can have quite severe outcomes, including hospitalization and even death. So I think that it is still an important scientific question to see if the vaccines can be safe and effective in children, because there may be benefit for those populations as well. The other reason is that children, while they're less likely to transmit, they can still transmit COVID-19. And so they can also contribute to infecting their families, and there may be higher risk people within their families. So there are several reasons why assessing vaccine in children remains important.
I know we got to go, but the other part of that question was, would they experience more symptoms compared to adults with the vaccine? Or is that kind of one of the questions they're trying to answer?
That would be one of the questions being asked in the trials.
All right, everyone. Hey, I know we've gone long. Thank you very much, especially to those of you on the panel who have taken the time out of your day. We really appreciate the effort you are making to help us overcome the challenges we face in reaching these different communities, whether those challenges be cultural, language, technology, mobility, geography. Those are all things that we're dealing with, and we appreciate the efforts that all you are making to help get the word out and get the vaccine to everyone and educate everyone on COVID. And Telly, great work in getting out into the various communities and lowering those numbers. That helps us all. So thank you very much. And thank you to members of the media who asked such thoughtful questions today. We appreciate it. You have seen in the chat that Josh Quint has put some links up for you, and you can go to our websites and you will find that the data is there for you visually, and that will be updated daily, Monday through Friday. Let's keep an eye on those numbers, and we hope that equity can be achieved as we march forward in the vaccination process and we all tamp down COVID. Everyone, do me a favor: wear your masks, avoid large gatherings, maintain social distance. Thanks much, everybody.